Vi ska nu få höra dagens tredje och sista presentation på engelska. Det är ett bolag som heter Visiopharm. Det är ett danskt bolag som vill listas på First North till hösten. Det här bolaget, jag säger det här nu på svenska lite så att ni vet vad de pratar om eftersom det blir engelsk-danska. Men det här är alltså ett bolag som tillhandahåller mjukvara för bildanalys vid patologiska undersökningar. Så det patologen gör idag är att man tittar i mikroskop. Men här har vi alltså en mjukvara som gör att man kan behandla bilderna i datorn. Det blir naturligtvis mycket enklare och effektivare på alla möjliga sätt. Och vi har med oss Visiopharms vd. Welcome, Michael.
Thank you very much, Charlotte. And very true, it's embarrassing. We did acquire a Swedish company in Lund about 1.5 years ago, and still the two only words I know in Swedish is fruktansvärt and smörgåstårta. And as our CFO pointed out, interestingly, they came in the same sentence. So what I want to talk about today is cancer and cancer diagnostics, or I should say maybe tissue diagnostics. Those are very serious topics, obviously. So before starting to talk about that, I want to talk a little bit about the good news first, because there is actually some good news. I'm sure a lot of you have heard about that. The new targeted therapies, also known as immunotherapies. What's interesting about them is that they don't just give an extension of lifetime, half a year or a year. We've seen end-stage patients with kilos of metastases in the body that would actually recover in a few months from that therapy. So that's the really good news. The other good news is that right now, as we speak, there are about 600 of these immunotherapies in late-stage drug development coming out on the market very shortly. When things start getting a little bit complicated, it's because we are talking about targeted therapies. As the name seems to suggest, it works on very narrow parts of the population, of the patient population. So just a few percentage of these patients will respond to one specific targeted therapy. So the big challenge in the healthcare, if we want to spend healthcare dollars or svenska kronor, whatever, if we want to spend that effectively, we absolutely need to find the right treatment for the right patient at the right time. And as I will talk about as we go into this, that is exactly the challenge that we've been having for many, many years because of the way tissue pathology has been practiced. And many of you probably don't know exactly what it is pathologists are doing. I'm hoping you get an idea by looking up here. Sorry, I need to go back. Where you can see that they're looking at these glass slides, and you can see they have very different colors, these glass slides. That's because those are different diagnostic tests that pathologists used to look at in these microscopes. Today, we can do something different. But we absolutely need a new gold standard, both when we talk about quality, but also when we talk about productivity of pathologists. But before I talk all about that in more detail, I want to talk a little bit about the team. I know that I have time restrictions, so I will not go into great detail here. But I want to mention, of course, our chairman, Patrick Dahlén. He is Swedish. He has a lot of experience when it comes to cancer diagnostics. He was chairman of, he was a CEO of DACO. Before they got sold to EQT, he knows the tissue diagnostic business extremely well, what barriers and what opportunities we have. And of course, he's also been involved in Immunovia, which is another very interesting company that you're very well familiar with. I also want to mention Susanne Højberg. Susanne Højberg used to be the chairman of our board, and she was there right from the beginning. She has, with her own hands, built, I would say, the strongest patent attorney company for life science companies in the Nordic countries. But we have many other competencies on the board. Thomas Weilby, the only external investor that we have for all these years, knows how to grow software companies. Henrik Stender, who has always been with Daco at Advandex, he has 13 FDA approvals under his belt. The two last horrible people I won't talk about because they plan to step out of the board quite soon, because we want to upgrade the board with some new members that unfortunately I can't talk about today, but they have very strong competences within the industry and even within immunotherapies and the diagnostics that we need in order to work with immunotherapies. The management team you see here, Johan, this gentleman here, is the co-founder. He and I met in a former life. My own background is as a PhD and postdoc at MIT and Harvard, working very much with image analysis for diagnostic purposes. And in my former lives, or two lives, I've built what you would call the technical founder of diagnostic companies, one for osteoporosis, dealing with bone quality, another for looking at diabetic retinopathy. I met Johan there and learned that there is, as Steve Jobs once put it, several orders of magnitude in difference in efficiency when you look at a mediocre and a star programmer. So I was very impressed with him. We started the company in 2001. We were operational in 2002. And since then, we've built a very experienced management team here with our CFO, financial background, Andreas. He's been working for many, many years with tissue diagnostics. He's our CSO. Thomas Ahl, our COO. He has worked in medical devices, as you can see, but he's also been part of the Danaher Corporation, so he knows how to drive strategy into an organization and into the market. And last but not least, Ulrich, who's been working, among others, for Microsoft, where he knows everything about healthcare IT. A little bit about the owners. We still own the founders, the majority of the company. I do want to mention Microinstrument in Skåne. We acquired them in an equity deal about 1.5 years ago because they know a lot about how to deploy digital pathology solutions into the market, but also because it's a family-owned company. They had been working for 30 years in the Swedish market, in the Swedish healthcare market. They know every single pathology lab in Sweden and had already sold to 2/3 of them. So in a way, we acquired both talent, experience, but also market access here in Sweden. We also, but that was more of a talent acquisition, acquired Amanda Lau's company many years ago. Her consultancy company name was Digital Pathology Consultants, but that was pure talent acquisition. She is what the Americans would probably call digital pathology royalty. So she's been in that field right from the beginning, and today she's heading up our US team that has grown tremendously over the last couple of years and contributes quite substantially both to our growth and our revenue. So that's really about the company and the team behind what we are doing here. I want to talk more about the problem. Of course, there are many cancer deaths. Even today, it's almost 9 million people dying every year. That's roughly the same as the entire population of Greater London every single year. And the incidence of cancer just keep going up, mainly because we are looking at aging populations. We, in our part of the world, we are aging at an alarming pace. When we talk about, that obviously drives a need for cancer diagnostics. And when I talk about cancer diagnostics, it's not determining whether or not people have cancer. There are many ways to do that. There are coming new ways to do that. When I talk about cancer diagnostics, it's really about figuring out what kind of cancer is it, what type of cancer, and what is the optimal treatment for the patient. And in very many cases, that decision, that diagnosis go through tissue pathology. And I will talk a little bit more about what tissue pathology is, because that seems to be something that only happens in the basement of a hospital. Very few people ever meet a pathologist, unless, of course, you have an autopsy performed on you, but then you are not really aware that you meet them. So let's talk a little bit about tissue pathology. What's really happening, and what I indicated right at the beginning, they're looking at tumor biopsies, and they're looking at very, very thin sections of tumor biopsies in a microscope. That's a highly, highly manual procedure. And as you probably won't be surprised when I say it's very labor intensive, it's time consuming, it's expensive. And if you look at pathologists today, they have a huge backlog of glass sitting on their desks, and they just can't keep up, both because the volumes are going up. There is a scarcity of pathologists in this world, and they're all nearing retirement age. So we have a severe bottleneck there. But what you probably don't know, and you won't be grateful when I tell you how bad this is, what you probably don't know is how inaccurate that diagnosis is in many cases. I'm going to tell you how inaccurate it is, but I'm also going to tell you why it's that inaccurate. And I'll also tell you, of course, what we can do about it. For now, I'll just say that knowing how inaccurate it is, the ability to digitize these slides also makes it possible to use image analysis and artificial intelligence in standardizing these tests and automating these tests, so you can actually get, and those numbers may not mean a lot to you right now, but we can improve the diagnostic accuracy with as much as 60% compared to where we are today. In the future, that will likely be more, if you even can do anything manually. We can also, because we do that automation, we can have what a Danish pathologist, head of department, says, an intelligent reallocation of work in the diagnostic pathology lab. It also means that we get improved turnaround times. People don't want to wait for a very long time getting that test back. This is serious. So it means a lot of saving and efficiencies throughout the whole process, and I will show you how and why that happens. In order to understand that, excuse me, we may have to look a little bit at the current workflow in a pathology lab. And first of all, a biopsy is surgically removed and it's fixed, typically in formalin, so it doesn't change. After that, it's embedded in paraffin. And once it's embedded in paraffin, that's what makes it possible to cut these ultra-thin slices of 3 to 5 microns. After that, it's being put into one of these machines, and you know the names of the companies who make those machines. That's Roche, that's Agilent, that's Leica. And they're producing diagnostic tests as reagents, and they use those reagents to stain those thin tissue sections so pathologists can look in a microscope and determine what is the optimal treatment for this particular patient. They can understand what type of tumor is this. That is written with many sources of errors and variability. And we have found out by looking at this for the last 15 years that major sources of variability is actually in the staining process. There are something called external quality assessment organizations that are not for profit, bandwidth limited organizations capable of doing tests for stain quality. And then, of course, the other huge error source is when people are trying to assess something by eyeballing in a microscope. That is a challenge. Now, not so many years ago, these slide scanners came out. They're not at all widespread yet, but they are becoming a commodity that can digitize at very, very high quality and very high resolution these slides. They're huge files, and you can navigate them just like Google Earth, looking at that tissue section. There's a pink section, then you zoom all the way down to the individual cells. That was a prerequisite for a whole new ecosystem of technologies and companies to evolve. One of them was ours, because we could take that image analysis platform that we have been developing since 2002 and apply that to these huge image files and use image analysis and artificial intelligence to do something about the problems I just mentioned, the reader variability and the staining quality. Now, it may sound a little bit strange that we have so much variability when looking at these tissue sections, but I think after the next section, you will understand what we're working with here. It's not because pathologists are not doing a good job. They're doing their best every single day, but they're also part of the human species. And the human species have serious limitation in the visual cognitive processes. So what you have to do in some tests is to look at where is the tumor, where is it growing most aggressively, how much are the cells dividing, and there are certain biomarkers where you simply have to find that area. That area is called a hotspot. It's very difficult in sections like this to pick out the hotspot. And as you can just see here, 3 pathologists didn't agree at all. None of them actually found the right location of the hotspot that we can compute with image analysis software. And in fact, there are scientific studies showing that less than 50% of pathologists are capable of correctly picking out the hottest hotspot. So that's one kind of error, where to read. The other error is what to read. And of course, I've simplified this a lot, but just to give you an impression. And you're only supposed to look at the invasive tumor cells in such a tumor. You can't look at all the other cells, but sometimes it's downright very, very difficult to distinguish. So you can imagine that a lot of variability comes from that particular aspect, that pathologists are sometimes not able to reproduce themselves and will assign different treatments to patients, to certain patients, depending on what day they're looking at that patient. And certainly you can imagine that pathologists find it even harder to reproduce each other's results. And I wish that was all, but it does get worse, because as I mentioned to you, we are looking at staining quality, and that, I'm sure, is super abstract. But let me try to make it very, very concrete. Breast cancer, the single biggest cancer form in any of our societies, 20% of all breast cancer patients have a specific gene, the HER2 gene, amplified. That was not a good prognosis many years ago until Genentech found a drug called Herceptin that would maybe not cure but vastly improve the diagnosis of HER2 positive women as that's called. So they also developed the world's first companion diagnostic, the HER2 test, that would pick out women with that gene amplified. Now, these are 2 sections taken from the same tumor biopsy of this woman. And here you can see that this is what the staining is supposed to look like. You can see a lot of brown. Those are the cell membranes that stain brown because she is HER2 amplified. And this is a HER2 positive that would immediately be referred to Herceptin treatment. But here in this lab, they did not stain correctly for whatever reason. No pathologist, no image analysis program would ever pick out this woman as HER2 positive, and she would not get the right treatment. The treatment she would get would be maybe costly, maybe even harmful, and in any case, it would be ineffective. And you would think this is a very esoteric problem. It is not. As much as 1 out of 3 pathology labs that are being monitored by these EQA organizations will not stain sufficiently. There are many reasons for this. One of them... thank you. So that's about 50% of patients that may be misdiagnosed. It will be even worse in the future when we are looking at new companion diagnostic tests. So what it is we have done is that we have developed software that that creates precision pathology and high throughput pathology that can solve all of these problems, and we can plug them in directly into existing workflows. So very briefly, what we've accomplished with a very, very small investment of no more than 10 million Danish kroner, 11 million Danish kroner, we've been able to grow the company to a revenue of 80 million Swedish kroner in last fiscal year. Unfortunately, we prepared this presentation a while back. If we'd used the current exchange rate, it would be 89 million Swedish kroner. And we also acquired this Swedish company, as I mentioned, that was really to gain market access. There is a great interest in this in Sweden as much as there is in Denmark. In Denmark, we have an 87% market penetration for breast cancer. 87% of all Danish women are being diagnosed with this new test today. In about 4 or 5 months, it will be 100%. After we acquired the Swedish company, one of the first results was that we won a major tender in the Västra Götaland region. It covers about 1.6 million people and about 9,000 cancer patients per year. And when we rolled this out in a few months, the breast cancer patients will be diagnosed using this type of software. We, of course, expect to roll out other types of diagnostic tests. Very briefly, this is our product offering. We have a software platform that's currently a perpetual license. We have a software maintenance agreement like most other companies do. You know that from your private purchases. And we have apps. We think about diagnostic applications as apps, and that's volume based on how many use it. Of course, this is emerging healthcare technology. People don't know how to consume it or acquire it, so we see different purchase patterns and price model requests different places. But in Sweden, they definitely want to buy this as almost like software as a service. You can imagine it's a very large theoretical market potential. I won't really talk so much about the numbers. I'll talk more about how we are rolling this out. So right now we've been growing very, very much, but it's expensive to grow. We have to face that, and we need to use this window of opportunity to get into many more markets. And it's simply too slow to grow direct sales organizations and do that organically. So I think we've taken away technology risk, we've taken away a lot of market risk, but right now the reason we seek to go on the stock exchange is that we want to build channel, and as Torben suggested before, and we've seen the very same thing, building direct channel is the most effective for us. obviously, we also want to build more content for this platform, and we can build content very, very quickly. And what we are looking at right now is, of course, that's interesting. It doesn't quite look like the one that all right. What we're looking at down here is the breast cancer. That's about 15%. The second largest indication we are looking at is lung cancer. And we are really looking in order of the larger cancer indications. And our platform is configurable. So you could say that our unfair advantage is that we can build new applications very rapidly, then get them improved and rolled out on this platform. And with that, I think I've almost stayed within the boundaries. Thank you very much.
Thank you, Michael.